Hi everyone, welcome. Please feel free to put your name in the chat and we'll get started in just a couple minutes or seconds rather. This is Notable Poisoning Trends, What You Need to Know. All right, and it is 12 p.m. so I'll get started here. So welcome. So my name is Claire and I am the Manager of Knowledge Translations and Programs at Parachute. And we're thrilled to welcome you today to the webinar, which will include 3 presentations exploring 3 different and notable poisoning trends in Canada. So please continue to introduce yourself in the chat. And we would like to begin today by acknowledging the land on which Parachute is located. For thousands of years, it has been the traditional territory of the Wendat, the Anishinaabe, the Haudenosaunee, the Métis, and the Mississaugas of the Credit First Nation. Today, this land is still the home to many Indigenous people, and we are grateful to have the opportunity to work on this land. And while we meet today on a virtual platform, we still encourage you all to take a moment to acknowledge the importance of the lands which we each call home. From coast to coast, we acknowledge the ancestral and unceded territory of the Inuit, Métis, and First Nation people that call this land home. So a few quick housekeeping items. This webinar is being recorded and all participants will be sent a link to view the recording at the end of the session. If you have any questions for our presenters, please use the Q&A button and we will address them all at the end of the session. And before you leave the webinar, you will be prompted to fill out a very short evaluation form. And we'd really appreciate your feedback on this session. It helps inform our work and it also makes sure that we're meeting your needs as well with these professional development sessions. And a couple quick plugs. This week is Poison Prevention Week. And so we'd like to say a quick thank you to all of our partners for their hard work throughout this week. It's really great to see the collaboration that takes place across networks during Poison Prevention Week. And I know here at Parachute, we're really thrilled to be a part of it. It is not too late to share if you haven't done so already. Parachute, as well as many of our injury and poison prevention partners, have been sharing some great resources. We are using the hashtags Check for Poisons and NPPW 2022, National Poison Prevention Week 2022. And on our website at this link here, you can find lots of great updated resources that you can use during Poison Prevention Week and beyond. And we also have just updated our High and Locked campaign and released some new images and videos. And our High and Locked campaign encourages parents and caregivers to properly store their cannabis and cannabis edibles high and locked. So there are lots of fun campaign videos there as well if you'd be interested in sharing those and accessing those. You can see them on our website right here at parachute.ca/highandlocked. All right, so for our webinar today, we have 3 presentations. The first will be by Alice Watt from ISTP Canada, the second by Samantha Power at BCIRPU, and our third and final presentation will be covering essential oils, and that will be provided by 4 speakers from Health Canada. So I'd like to just introduce our first presenter. So we have Alice Watt from ISTP Canada. Alice received her Bachelor of Science Pharmacy degree from the University of British Columbia. She has more than 20 years of experience in, let me just stop sharing there, and in community and acute care settings. She joined ISTP Canada in 2007 as a medication safety specialist and is also actively practicing in a community hospital as a clinical pharmacist. In her role at ISTP Canada, she is involved in medication safety incident analysis and is the lead for the 5 Questions Initiative. She's passionate about engaging patients and healthcare practitioners in safe medication practices. All right, well, we're thrilled to have you with us today, Alice. Take it away.
Oh, thank you very much, Claire, and I'm thrilled to be here. Hello and good afternoon, everyone. It is Poison Prevention Week, and so I am delighted to be here today to share with you some selected medication-related poisonings related and reported to ISTP Canada. Today, we'd like to help you understand how medication error reporting and learning can support poison prevention and describe the actions that ISTP Canada has taken to help raise awareness of poisonings and to prevent future occurrences. ISTP Canada is a national, independent, and not-for-profit organization dedicated to reducing preventable harm from medications. Our vision is zero preventable harm from medications, and our mission is to identify risks in medication use systems, recommend optimal system safeguards, and advocate for safe medication practices. We have a unique role in Canada as a trusted partner in strengthening medication safety through timely learning, sharing, and acting to improve healthcare. We are a part of the Canadian Medication Incident Reporting and Prevention System, and we receive incidents from healthcare providers, consumers, and community pharmacies. The incidents I'm about to share today have been reported by consumers and healthcare providers, and first I will start with the incidents from consumers. There are literally hundreds of products, both prescription and non-prescription, that contain acetaminophen in Canada. ISTP Canada has helped to advocate for clearer labeling of products containing acetaminophen and for now, they contain a label on the top right corner to help consumers select the right product. As in this photo. This was shared with us by a reporter whose child was prescribed acetaminophen 325 milligrams, one tablet every 4 hours as needed. This reporter nearly gave the tablet in this bottle, but her child stopped her to tell her it was the wrong dose. Can you spot the correct dose on this label? I'll give you a second to look and see if you can find the correct strength. The outcome for this was a good catch and no harm, but as you can see on the bottom right, the small little words of 500 milligrams for each tablet. And so one of the contributing factors to this error was the prominence of the number 325 in bold red font, indicating the tablet count. This outcome did not cause any harm, but could have caused acetaminophen toxicity. ISTP Canada contacted the manufacturer to report the incident and to advocate for label improvements. Smart kid. Our next consumer report describes a young child who drank a liquid medication directly from the bottle. This bottle had been provided to a child care center so that the daytime dose could be given by staff. However, the child found the bottle in her lunch kit and thought it was a drink. The parent's child was alerted to the incident and called a poison center for guidance, and the child experienced mild side effects. The parent reported that the bottle did not have any type of child-resistant closure. ISTP Canada therefore contacted the manufacturer of the product to inform them of the incident, and they're now working on ensuring that packaging incorporates child-resistant closures. Now, even though child-resistant closures are used, they are not often always childproof. We also received another report of a young child who accessed medications by opening the containers all by themselves. One bottle had a child-resistant safety cap that was not properly secured. We recently posted this on social media this week for Poison Prevention Week, and we received a response that a similar incident happened with their child. They wrote, "This is true. When my youngest was 4, she took her own dose of children's Tylenol. I asked her how she opened it, and she said, the lid has instructions." So we continue to share messaging to help keep medications stored high and locked up. ISTP Canada also received a recent report from a concerned consumer who picked up a bottle thinking it contained a drink, but soon realized it was hand sanitizer. They shared that the product inside the bottle was a liquid, not a gel, and it looked just like water. He was concerned that the product might be ingested. ISMP, near the beginning of the pandemic, sent out a national alert to warn Canadians and healthcare providers of this issue, and also provided other examples. Shortly after that alert, we received another report about a child who started to drink from a container that looked like a water bottle. The bottle contained hand sanitizer, and fortunately the child did not swallow the liquid but did feel burning in her mouth. ISMP Canada sent out an alert to all healthcare providers, community pharmacies, and patients, and shared this newsletter to increase the awareness not to stock or purchase these types of products. We started to get more reports of poisonings with hand sanitizers, and the one on the left is from IWK that was shared with us, and so we continue to share these on our social media channels and in our bulletin. Now I'll switch gears and share some of the reports from healthcare providers. In 2006, ISMP Canada was invited to review a fatal incident involving the administration of high-dose fluorouracil, a chemotherapy agent that was given over 4 hours instead of 4 days. A root cause analysis determined that a poison information center was not considered as an additional information resource in the initial management of the fluorouracil overdose, and the recommendation was to develop a protocol for dealing with this potentially serious medication instance that includes the need to consider contacting the Regional Poison Information Center. That includes emergency departments who accept patients with poisonings, as well as medication errors in hospitals, community pharmacies, long-term care homes, and primary care clinics. And this was what started our strong relationship with poison control centers in Canada. Here's an incident of a child that was given a first dose of an antibiotic suspension that had been reconstituted and dispensed by a community pharmacy. However, shortly after ingesting the dose, the child gagged and vomited. The pharmacist called the child's parents and asked them to smell the antibiotic liquid. The parents reported that it smelled like vinegar, and so the pharmacy then acknowledged that vinegar instead of distilled water had likely been used in error to reconstitute the medication. We also received several near-miss reports from pharmacies who nearly reconstituted medications with diluted bleach, and they show an example of what their container may have looked like when they put the bleach label on one side with the water label on the other side. ISMP wrote an alert to warn pharmacies and healthcare providers about this issue. We also received a report from a healthcare provider through Health Canada about a pediatric patient who was prescribed a CBD-dominant cannabis oil product by a specialist for an uncontrolled disorder. The caregiver had selected, purchased, and administered 20 milligram per mil THC product instead of the CBD product due to wrong product selection. One of the contributing factors was the look-alike labeling on the packaging. We shared this incident on our Med Safety Exchange webinar on May 19th, and if you'd like to learn more, please check out the link. We're also working on a consumer newsletter, which will be out later this year. Next, we recently shared 2 reports of poisonings related to methotrexate given to patients with end-stage renal disease. You may be familiar with methotrexate toxicity from patients who mistakenly took their methotrexate daily instead of weekly, but in these 2 cases, the toxicity was due to the patient's poor kidney function, and this may not always be something that healthcare providers are aware of when prescribing methotrexate. In these 2 cases, the outcome was severe harm and death, and we shared it in our recent safety bulletin. Here is an incident reported by a hospital where a patient was ordered 1 milligram of hydromorphone, but was inadvertently given 50 milligrams of hydromorphone in an IV bag all at once as a bolus. The error was discovered after the patient was found to have an altered level of consciousness, and naloxone had to be given. As you can see by the label on the left, the prominence of the 1 milligram per mil led to the misinterpretation of critical information on this bag. As a result of sharing this incident, ISTP Canada worked closely with the manufacturer to make improvements to the label so that the information about the total amount of hydromorphone in the bag, 50 milligrams in 50 ml, is now the most prominent on the bag, and a new secondary label statement has been added, which reads, "Slow infusion only, fatal if not infused slowly." Now I'll talk about some of the safe storage and disposal of medication resources that we have shared and we have on our website. In our newsletters, we remind consumers to return unused medications to the pharmacy for safe disposal and not to throw the medication into the garbage. We also embed safe storage and disposal of medications information in our opioid handouts. We have created patient handouts for opioids and have resources about how to use naloxone as well. And you can access these resources at opioidstewardship.ca. ISTP Canada has also developed an e-learning module for first-year medical students about the safe storage and disposal of opioids to help raise awareness about the importance of counseling patients when opioids are prescribed. As you can see, the reports we have received make a difference, and it is so important, such an important part of our work, learning from incidents and then sharing back the information with recommendations. We work with industry, organizations, Health Canada, and regulators to be able to find system-based solutions to problems that have been brought to our attention. Mederror.ca is a platform for consumers to report medication errors. It was co-designed by patients and providers to give people a way to share their medication story with us. Every report that comes into ISTP Canada through Mederror gets analyzed, and the reporter is contacted if they wish. On the right is our IPR reporting link. That stands for Individual Practitioner Reporting. Any practitioner can also report to us with that link as well, and these reports are also reviewed by our analysis teams. Many of these reports have led to significant changes in packaging and labeling, similar to what I've just shared. Prevention of poisonings is such an important topic to us all, and to me personally, as it is near and dear to my heart. I had a close call many years ago when my toddler had gotten into my arthritis pills. Now, as a pharmacist, I know how important it is to keep my medications stored up and away, but I didn't imagine that my little 18-month-old could climb up onto my washroom counter and open my compliance pack. I found him just before he took any of my medication, which is on the 1 pill can kill list. First lesson learned, compliance packs are not child resistant. I still think about it sometimes and I shudder. And ever since then, I've always kept my medicine in this. It's a toolbox with a lock on it. Lesson 2, keeping medications high is not enough. They need to be high and locked. Now that my son is 10, and even up until recently, he asked me during COVID, when school was virtual and he was home all day, every day, he watched me take my pills. And he looked at this vial and he asked me, "Mom, can I have a mint?" I looked at him to see if he was serious. And I said, "What do you mean?" And I took a closer look at my vial. And then I realized he had read the word mint on the vial. And that was the name of the manufacturer. Phew, we averted yet another close call. Lesson number 3, older kids can read labels and poisonings can happen to them too. And the last lesson is that poison control centers are a lifesaver. I am so grateful for all of you who are listening today who work in poison prevention and in the poison centers. Always the calm voice at the end of the line, especially in harrowing times that parents sometimes find themselves in. Thank you for all that you do. As an emergency department pharmacist, we also work with you all the time, and we certainly do appreciate all that you do every day, 24/7. ISTP Canada is proud to partner with you and to help advance and disseminate the important work that you do. So we're so glad to be here. Thank you so much for the opportunity to share today. And if you'd like to stay connected, please do follow us on social media or sign up for our newsletters and bulletins. Feel free to put your questions into the chat or email me at alice.watt@isnpcanada.ca. And thank you very much.
Great. Thank you so much, Alice, for that presentation. It's really fantastic to see all the work that ISNP Canada does to increase awareness. And thank you for sharing those reporting avenues. I know those are going to be really useful. I'd like to now introduce our next presenter. So Samantha Power is a research assistant at BC Injury Research and Prevention Unit and a medical student at the University of British Columbia, where she recently completed a Bachelor of Science degree. At the BC Injury and Research Prevention Unit, Samantha's work has focused on poisonings in BC, particularly self-harm poisonings among children and youth. So we're happy to have you today, Samantha, and take it away.
All right, thank you. I'm just gonna share my screen here. All right, so hopefully everyone can see that all right. And thank you for the introduction. So briefly, the presentation today is going to cover some background information about the project, and then the objectives, what we aim to achieve when doing this work, our methods that we did to complete the project, the results that we found, and then I'm also going to discuss what we found and the conclusions that we made from the results. So poisoning is the most common method of self-harm for children and youth. And recent studies in both Canada and the United States have shown increase in adolescent self-poisoning. So for example, there was a study out of Newfoundland and Labrador, and they found that self-poisoning hospitalizations among 12 to 17-year-olds increased 2.7-fold from 2008 to 2013. While across the entire United States, there was a nearly 300% increase in self-harm poisonings among 10 to 15-year-olds, and that was from 2000 to 2018. It's not exactly known why they're seeing increasing rates of self-poisoning among these young people. However, the study in Newfoundland and Labrador did suggest that mental health may be playing a role with increasing rates of mental health issues coming about. And then there was also other studies in the literature that support a link between socioeconomic status and general injury rates, with those of low socioeconomic status having higher injury rates. So that was something we wanted to explore for self-harm poisoning. For our objectives, the first one was to assess self-poisoning rates among British Columbians to identify those who are at high risk of poisoning or self-harm poisoning. And then the second objective was to describe self-poisoning rates specifically among 10 to 19-year-olds. And we did this by socioeconomic status and geography of residence. And then we wanted to evaluate the distribution of mental health services throughout the province so that we could compare access to these services to rates of local self-harm poisoning rates among children and youth. And this was done by each census division. And then our fourth objective was to identify common substances involved in these self-harm poisoning hospitalizations among the 10 to 19-year-olds in BC. So the methods that we did involved calculating rates for self-harm poisoning hospitalizations, and this was during the 2009-10 to 2016-17 fiscal years. And we calculated rates by age group and by sex. And this was done by extracting self-harm poisoning hospitalization data from the discharge abstract database. And then we divided this by the relevant population size. And this information was obtained from Stats Canada. And then we just multiplied by 100,000 to get rates per 100,000 population. And we used the Canada Deprivation Index, which was created by the INSPQ in Quebec. to calculate rates for socioeconomic status. So this index uses the Canadian population information, and they divide it into material and social deprivation quintiles based on neighborhood of residence. And self-poisoning hospitalization rates for 10 to 19-year-olds were calculated for both material and social deprivation. And this was used as a proxy for socioeconomic status. Child and youth self-poisoning hospitalization rates were also calculated by census division, which is where they lived, not where they were actually poisoned or where they were hospitalized. And then finally, the self-poisoning rates for 10 to 19-year-olds were also geospatially mapped with respect to where local mental health resources are. So these would be in-person places offering mental health services specifically for children and youth. So to talk a little bit more about the INSPQ deprivation index, this is a neighborhood deprivation index, again, using Stats Canada census data, and it uses data for those aged 15 years and older. And different characteristics are used to determine material deprivation and social deprivation. So for material deprivation, they consider the proportion of individuals who have not obtained a secondary school diploma, the employment to population ratio, as well as the average income of those living within the neighborhood. And then for social deprivation, they include factors such as the proportion of individuals who live alone, the proportion of those who are separated, divorced, or widowed, and then the proportion of single-parent families living in that neighborhood. So now to jump into some of the results. From 2009-10 to 2016-17, self-poisoning rates among 10 to 14-year-olds increased 2.7-fold. And this reached a rate of 65 per 100,000 population. And that is seen in the orange line in the graph, the 10 to 14-year-olds. And then meanwhile, for 15 to 19-year-olds, so that would be the darker blue line on the top, there was an increase in self-harm poisoning hospitalizations of 1.7-fold. And this reached a rate of 180 per 100,000 population. So as we can see here in this figure, the only two age groups really that saw increasing rates over the study period were the 10 to 14-year-olds and the 15 to 19-year-olds, with the 15 to 19-year-olds having the highest rate in every single year of the study period. So when we saw this graph, this was one of the main reasons why we decided to focus on 10 to 19-year-olds for self-harm poisoning hospitalizations, because the rates were so high and still increasing over time. The highest self-poisoning hospitalization rates were among 15 to 19-year-old females. And this rate was quite high at 225 per 100,000 population. Meanwhile, males of the same age group had significantly lower rates of 56 per 100,000 population. And then for 10 to 14-year-olds, there's also a large difference between males and females. And this further supports our conclusions that females are really the driving force behind these high rates among children and youth. So jumping now into the deprivation analyses, when we looked at self-poisoning hospitalization rates among 10 to 19-year-olds by material deprivation, with the first quintile being the least deprived and the fifth quintile being the most deprived, there was no clear relationship with the rates and the material deprivation. However, when we did the analysis by social deprivation, the results looked a little bit different. So when we calculated rates for 10 to 19-year-olds by social deprivation, we can see here that in between the fourth and the fifth quintile, so again, the fifth would be the most socially deprived neighborhoods, there was a significant increase in self-harm poisoning hospitalization rates. And in the most deprived neighborhoods, the rate of self-harm poisoning hospitalizations was over 200 per 100,000 population. So again, quite high. So this here can maybe look a little overwhelming, so I'm just gonna walk everyone through it. It's a heat map of child and youth self-poisoning hospitalization rates by BC Census Division. So the little blue dots on the map are individual mental health services that are specifically available for children and youth. And then the green dots with a number inside of them are clusters of youth mental health services. The census division with the highest rates were generally located in more rural regions of the province. So the highest rates were in Skeena Queen Charlotte, which is in the center on the left side of the map. And the rate there was 423 per 100,000 population, so very high. And then the second highest census division with the second highest rates was the Central Coast, which was just below Skeena Queen Charlotte on the map there. And then the third highest self-harm poisoning hospitalization rates were in the Northern Rockies census division. So that's up in the northeast corner of the province. And then what we noticed was that in the census divisions with the highest rates of child and youth self-harm poisoning hospitalizations, we can see on the map that there's generally poorly distributed mental health services, and especially in the Central Coast and the Northern Rockies, there's not that many of them in general. So yeah, we found that quite interesting when looking at this map. In terms of substances, non-opioid analgesics, antipyretics, and antirheumatics, so for example, acetaminophen and ibuprofen, were the most common substances used by 10 to 14 and 15 to 19-year-olds who were admitted to BC hospitals for self-harm poisonings. And then the second most common substances were anti-epileptic, sedative, hypnotic, anti-Parkinsonism, and psychotropic drugs. So for example, antidepressants. And there were other substances also used by children and youth who did end up being hospitalized for self-harm poisoning. However, after these two categories, there was a significant drop-off. So I've just highlighted the top two categories. So the conclusions from these findings is that children and youth living in physically and socially isolated neighborhoods with poorer access to mental health services were found to have the highest rates of self-harm poisoning hospitalizations in BC. And in order to decrease these rates, it's important to address the social gradient within the province and also work to equitable access towards mental health services, which were sparse in many rural regions throughout the province. Additionally, there are some potential public health solutions that may decrease rates of self-harm in this population. One example is the Sources of Strength program. And this is a suicide prevention program that was evaluated in random controlled trials in the United States. They had 18 high schools participating, and 12 of them were actually in rural regions of the United States. And this program was found to increase students' connectedness to adults, increase their school engagement, perception of adult support, and acceptability of help-seeking behavior, and decrease their maladaptive coping behaviors. So this program is a pretty good option, not only because it was shown to be effective in rural youth, but also because it increases help-seeking behaviors. And this is found in the literature to be more challenging for youth in socially deprived areas or with lower social supports. And then another program that could be helpful to implement in BC or other provinces is the Signs of Self-Injury program. So this is another secondary school program, and it's targeted for both staff and students to learn more about non-suicidal self-injury. It was evaluated in the United States as well and used 5 schools with pre-post surveys. And it was shown to increase knowledge among students and staff about non-suicidal self-injury and improved student preparedness to seek help, which again was a key issue for those in more socially deprived neighborhoods or with lower social connectedness. So that is everything for my presentation. Just wanted to thank everyone who contributed to this research. So Dr. Ian Pike, Faraj Abali, Alex Sang, Jennifer Smith, Anand Dat, and Dr. Roy Purcell. And I have included some references that I used throughout the presentation. And just wanted to thank everyone for listening.
Wonderful. Thanks, Samantha. It was a great presentation, and it's really helpful to see this type of analysis on such a concerning trend. So thanks very much for being here and for presenting. Next up, we have from Health Canada, we have 4 presenters with us today. So we have Dr. Laurie Chapman, who has worked with Health Canada as a scientific evaluator of therapeutic health products in the Natural Health Products Program since 2002. She has worked in both the pre-market regulation of natural health products with the Natural and Non-Prescription Health Products Directorate and in post-market pharmacovigilance with the Marketed Health Products Directorate, both within the Health Products and Food branch of Health Canada. Dana Kears-Justin is the supervisor of the Health Products Compliance and Enforcement Unit. She and her team provide national triage and coordination support related to suspected non-compliances for health products in Canada. Dana has been with Health Canada for 10 years, and in addition to her current role, has gained valuable experience from the Medical Device Compliance Program and the Medical Device Mandatory Reporting Program. We also have Christine McRoberts, who works in regulatory affairs at the Natural and Non-Prescription Health Products Directorate, working on product classification of natural health products. And we also have Jessica Roberts, who started an assignment at the acting unit head of toxicology in the risk assessment division of the Consumer and Hazardous Product Safety Directorate in the Healthy Environments and Consumer Safety branch in 2020 and deployed there in August 2021. She has 20 years of experience working in pesticide risk management, evaluating the efficacy and safety of domestic use pesticides and industrial use agrochemicals, and is now enjoying learning about the world of cosmetics and consumer products. So I'm going to control the slides for this session. So let me just throw them up and I will hand it over to Health Canada.
Apologies, I believe I was on mute. I'm Christine McRoberts. I work at the Natural and Non-Prescription Health Products Directorate, and I'll be speaking about the classification of essential oils as natural health products and the requirements for authorization for sale of NHPs, natural health products, in Canada. My colleagues will then be speaking about essential oils as cosmetics and consumer products and reporting of diverse reactions and complaints. Next slide, please. So essential oil products are classified and regulated differently depending on how they are represented for use. Generally, they are considered natural health products, consumer products, cosmetics, foods, or pest control products. Or an essential oil could also be considered a non-prescription drug and require a DIN if it's represented for use as a hard surface disinfectant. And one product cannot be classified as 2 things other than a cosmetic and a consumer product. So essential oil products may be represented as a single 100% essential oil, blends of essential oils with other ingredients such as carrier oils or water, or in other formats like bath salts, lotions, etc. The classification is dependent upon the representation of use of the product. So representation includes any indications of use or claims presented as a word, a sentence, a picture, a symbol, a paragraph, or an implication on product labels, package inserts, or advertisements, including websites, and representations may be explicit or implied. So some examples here show that the sage eucalyptus oil is considered a natural health product as it's represented for use to soothe respiratory discomfort, whereas the Now brand eucalyptus oil would be considered a cosmetic product as it's not represented for therapeutic use. So similarly, the oregano oil here is represented as a flavor, but there are also oral oregano essential oil products for therapeutic use, which would be considered NHPs. So any change to representation can change the classification of the product. Next slide, please. So if no health claim or therapeutic claim is made, An essential oil product would be considered a consumer product if it's represented for use, for example, in a diffuser or with or without a carrier, for example, a home fragrance. It would be considered a cosmetic if it's represented for use with a cosmetic purpose, for example, a perfume. It could be both a consumer product and a cosmetic if, for example, it's sold with directions of use on adding to a diffuser and adding to a carrier oil for use as a perfume to be applied to skin. It could be considered a food if it's represented for use as a food or drink or an ingredient to be mixed with food. For example, a flavor like the oregano flavor in the first slide. It could also be considered a pest control product if it's represented for use in controlling, destroying, attracting, or repelling a pest. So for example, insect repellents. Next slide, please. And finally, so essential oil products would be considered natural health product if it makes a therapeutic claim, for in other words, a health claim, or there's any therapeutic representation for use. And that would be, again, explicit, or it could be implied. And all natural health products are subject to the natural health product regulations under the Food and Drugs Act. And some essential oil products could be subject to the Tobacco and Vaping Products Act unless specifically excluded. To be legally sold in Canada, all natural health products must undergo pre-market review to ensure they meet the requirements of the natural health product regulations pertaining to the safety and efficacy of the product. So they must have a product license, so an NPN, and the Canadian sites that manufacture, package, label, and import these products must have site licenses. So NHPs must contain on their label the product NPN, the list of medicinal and non-medicinal ingredients, the recommended use, so the health claim or claims, directions of use, including dose information and route of administration, if not self-evident, risk information, so any warning statements, as well as other information such as company information, expiry date, lot number, etc. And there are exceptions made for products in small packaging. An outer label or attached leaflet may contain some of the information required on the label. So for the authorization of natural health products, so some products may meet the parameters outlined in NNHPD's, so Natural Health Products Directorate's Aromatherapy monograph to support the safety and efficacy of the product. NNHPD monographs provide information supporting the safety and efficacy of medicinal ingredients that the NNHPD has reviewed and determined to be acceptable and are used to issue market approvals for natural health products. So monographs are also a reliable source of information, of product information for consumers. And the Aromatherapy monograph contains information on 75 essential oils, including the route of administration, which is topical and for topical use or inhalation use. The monograph does not support an oral use. The recommended uses, so health claims, for example, used in aromatherapy to help relieve headache. There's information on the subpopulation. So in this case, adults only, 18 years and older. And again, the monograph does not support use in children, as well as there's information on the directions of use, so which vary depending on the route of administration. So for example, direct inhalation to be used in the bath, topical application. There's also information on the duration of use, which in this case is for occasional use only, as well as the required risk statements. So warning information. For example, to keep out of reach of children, if accidental ingestion occurs, seek medical attention or contact a poison control center. And for products which do not meet the monograph, additional evidence must be provided in order to obtain a product license. And this guidance document linked here provides the evidence requirements or outlines the evidence requirements to support the safety and efficacy of aromatherapy products which don't fully meet the monograph. And I believe there'll be time for questions at the end, but otherwise you can contact us directly at the Natural and Non-Prescription Health Products Directorate at the email address provided. And now I'll turn it over to my colleague, Jessica Roberts.
Thank you very much, Christine. So my name is Jessica Roberts, and I'm presenting today on behalf of the Consumer and Hazardous Products Safety Directorate. So CHPSD regulates two types of products. So we regulate cosmetics and consumer products. For cosmetics, they're basically products that don't have a health claim, but they do have an intent to cleanse or improve the complexion. It also includes deodorants and perfumes. So in the context of essential oils, you generally find them in such products as soaps, lotions, shampoos, bath products, perfumes, massage oils, and makeup. Cosmetics are regulated under the Food and Drug Act, specifically under the cosmetic regulations. In contrast, consumer products are those that do not have a health claim and are not cosmetic, but they are reasonably available to consumers. So it's a little bit of a catch-all for other products. Again, in the context of essential oils, you can find them in air fresheners or diffusers, scented candles, laundry pods, household cleansers, and do-it-yourself arts and crafts. And consumer products are regulated under the CCPSA, and I believe there's quite a few, like 32 different regulations underneath there. Next slide, please. So when you purchase a vial of 100% essential oil, you're not purchasing a vial with one chemical in it. There's various different ingredients within there. And these can vary from batch to batch and from year to year based on various different reasons. Mainly the botanical source, the genus and species, where you extracted it from, whether it's the fruit, the roots, the leaves, the seeds. The environmental growing conditions can also affect this. So whether it was hot and dry or cool and wet, and the extraction method. So if you use a heat extraction method, a cold press, or a solvent extraction, this can favor what are the constituent ingredients and what are their concentrations. In terms of toxicity, not all components of an essential oil are hazardous to health, but some of them may be. Some may pose acute risks depending on the exposure, while others have chronic risks. So you won't see these risks unless you use it on a regular basis after months or years of use. In terms of regulations, CHPSD regulates cosmetics through the cosmetic ingredient hot list. This is basically an online list that informs manufacturers what ingredients can be put into a cosmetic and what can't be put into a cosmetic. And if you are allowed to have them in, that means they're restricted, then they have certain associations. So it could be a limit on the concentration, it could be a label statement, could be warning statements. So it really depends on the essential oil you're talking about. Not all essential oils are listed on the hot list. We do try and add them every year, try and add new ingredients, but we're limited in terms of manpower and effort, and new essential oils are actually always coming on the market. Regarding incident reporting, CHPSD has its own reporting portal, and I put a link to that at the end of this presentation. So when a consumer uses a product, whether it's a cosmetic or consumer product, and has a reaction, whether it's a small reaction or a large reaction, resulting in injury, or it could be death in some cases, or even if they have a problem with the labeling or they don't understand the labeling or how it should be used, they're encouraged to report it. Underneath our current regulations for cosmetics, unfortunately, it's not mandatory to report, it's voluntary, but under the consumer product regulations, yes, it is mandatory. So in other words, if someone has a problem with a product, they report it to the store that they purchased it from, and that store is responsible for reporting it to Health Canada. Next slide, please. So what are the health effects? As I mentioned before, we have both acute effects and chronic effects. And these, well, acute effects really depends on many different situations. What's the essential oil that's being used? What's the route of exposure? If something's supposed to be used like a little cap full of a bubble bath, for example, in a big bathtub of water, the dermal exposure is going to be quite low. But if you happen to, young child comes by, opens up the container that has a bubble bath and swallows it, then that's going to be a very different route of exposure. It also depends on the dermal absorption characteristics, the quantity that that person is exposed to, the concentration of the components of concern within there. Again, these vary from batch to batch and year to year, age of the user, frequency of use, and individual hypersensitivity. So in terms of what are the symptoms, it could be anything from quite minor, a rash or hives, all the way up to something quite significant, such as anaphylaxis, coma, or death in some cases. In terms of the chronic effects, again, these aren't seen unless you have regular use after months and years. So some of the effects can include, tumor production, or might have reproductive or developmental effects. And again, these are why we review these to put them on the hot list, either as a prohibited substance or restricted to establish safe use limits. We also take a look at vulnerable populations. So if something does have a reproductive or developmental effect, then we will put on appropriate labeling statements to prevent those who are pregnant or looking to become pregnant from using it. In terms of its incidences, as I mentioned, we do have a reporting portal. The basic cause of these, probably the biggest ones we see are unknown hypersensitivity. So someone buys a new essential oil or a product that has essential oil in it, doesn't know that they're sensitive to it, and then has a bad reaction to it. Unintended digestion is a big one, mainly for children, but also for seniors with dementia. We see a lot of cases where they eat the laundry pods thinking that they're candy. So it's not just young children, it's all age groups that can be exposed. Not reading or following the directions for use is a big one as well. We had one consumer that had like a vapor puck that you're supposed to put into the bathtub, turn the shower on, and then kind of breathe in the fumes. They didn't read the directions for use. They got a bowl of hot water, put the puck in, put their head over with a towel over it, and then within minutes became overwhelmed by the fumes, had a seizure, and then hit his head when he fell down to the floor. So read your directions for use. Using a product in undiluted state or overuse is another example. Next slide, please. So poison center information that's useful for risk assessment. So first of all, I want to say that CHPSD does reach out to the poison centers. We do ask for data. We do use the data. We super appreciate this. We wish we could ask for more data, but that would be a little bit greedy. So how do we use this? So everything that's reported, the product, the use, how much was consumed, what was the form of the product, was it liquid that could be swallowed, is it a solid? Were there any label warnings on there? What was the age of the person? Symptoms and what's the final outcome? So all of this goes in to inform our risk assessments. So we update our risk assessments appropriately. And then from that, our risk managers are able to update relevant guidance for a policy document such as the hot list. So they can adjust maximum concentration limits or add additional label warning statements. Next slide, please. So that's it for my presentation. I did put up 3 links here. The first one is a link to our program under CHPSD, where you can get information on cosmetics and consumer products. The second one is where to report an incident. And the third one is just a link to our cosmetic ingredient hot list that outlines which ingredients are prohibited and which ones are restricted. And now I believe I'm going to introduce Dr. Lori Chapman, who will be presenting on marketed health products. Thank you.
Hi, Claire. We are on slide 12. Hi, I'm Lori Chapman, Scientific Evaluator with Health Canada's Marketed Health Products Directorate. I would like to point out that there is a distinction in reporting for health product side effects versus health product, consumer product, and cosmetic product complaints. The focus of these next slides is on side effect reporting for authorized health products, so those with a drug identification number or a natural health product number, a DIN or an NPN on the label. Health Canada collects reports of adverse reactions to these products through the Canada Vigilance Program. As you can see in this slide, most adverse reaction reports are for pharmaceutical drug products, and we might only receive around 500 reports for natural health products in a given year. The next slide, Claire. I have provided a high-level example of reporting trends, and I would also like to point out that due to underreporting, the case report numbers from Canada Vigilance do not reflect the actual incidence of cases or exposures. The key culprits are eucalyptus, tea tree oil, oregano oil, and I could also add clove oil. Accidental exposure, especially for children, does come up as a top term, and also wrong product administered. Other top terms suggest allergic reactions, hypersensitivity, or anaphylactic reactions. Reports include both young children and adults. So the first challenge we have to face for essential oils is underreporting. You can help by reporting serious, unexpected adverse reactions to confirmed health products. The link will be provided in the deck for participants. The quality of the reports received is critical. We need product information, ingredient information, and Health Canada registration numbers to allow us to confirm the product labeling. And we need medical information such as doses used, medical confirmation of reactions experienced, and re-challenge and de-challenge outcomes to support causality determinations and any potential regulatory actions. And now onto complaint reporting. Claire, if you could please turn to slide 17.
I have to remember to unmute. Thanks, Laurie. Hi, everyone. My name is Dana, and I work in the Regulatory Operations and Enforcement Branch at Health Canada. So the focus of our program is to verify and monitor the compliance of drugs and natural health products in Canada. Next slide, please. We assess complaints and referrals from various sources. Through our triage process, we're able to identify cases requiring compliance verification and follow-up when non-compliances are confirmed. The measures to do this to restoring compliance include sending compliance letters, on-site visits, stop sales, seizures, license suspensions, recalls, and public communications. We also leverage our data to conduct compliance promotion and monitoring activities. This helps to determine appropriate long-term mitigation measures or to identify trends where further guidance is required for industry. Next slide, please. When it comes to the compliance and enforcement data for essential oils, we were able to identify 279 cases since 2014. It is important to note that this search was conducted using keywords, and in some of the cases, essential oils were not the sole factor in the case. Rather, they were sometimes only listed as an ingredient or component of an implicated product. The majority of the cases identified involved an unauthorized product, and only a small number involved an authorized product. Additionally, of these 279 cases, 19 cases referenced an adverse reaction, for which only 2 involved an authorized product. These were actually hand sanitizers in the last couple of years that had contained essential oils as an ingredient. In all of these cases, a variety of compliance and enforcement measures were taken to address the concerns. This included following up with companies to address unauthorized products being advertised as health products available for sale in Canada. As such, stop sales or removal or amendments to the non-compliant advertising were important measures taken to ensure that these products were no longer made available to Canadians. Next slide, please. Finally, I'd like to highlight our contact information as well as other links that may be of interest. The first is our health product compliance and enforcement generic email. So this can be used for any general inquiries related to compliance and enforcement of health products. The second is the recalls and safety alert database. This includes all information on recalls, as well as public communications that have been issued. The last link is our health product complaint form. This is the preferred method for submitting a complaint, and as mentioned earlier, it goes directly to our triage group for processing. This form includes all the necessary information for reporting potential health and safety or quality issues related to drugs and natural health products. And that concludes the Health Canada portion.
Great, thank you so much, Jessica, Dana, Christine, and Laurie. Really appreciate you being here today and providing that presentation to us. I'd like to now turn it over to my colleague, Stephanie Cowell, who's the Director of Knowledge Translation at Parachute, who's going to facilitate a Q&A session. If all of our presenters would like to invite you to come back on with your camera, and we'll start the Q&A session. Thanks so much.
Great. Yeah, thanks everyone. Really informative presentations, lots of different trends we've examined here today, and lots of great interaction in the chat. So your presentations are all really well received by those in attendance. We do have some questions, so we'll dive right in. I'm going to start with one. Alice, you did already answer in the Q&A section, but particularly for those who might be watching the recording after, I'd like to just pull the question out verbally and give you a chance to respond. So the question was about the incident reporting to ISMP Canada and whether all incidents reported are related to packaging and labeling and whether vaccines fall under ISMP Canada's jurisdiction.
Yeah, thank you so much for that question. ISMP Canada receives incidents involving medications, and sometimes they relate to packaging, labeling, and sometimes they don't. And so we do have a check mark on the actual reporting document that actually can, if it is related to packaging and labeling, you can check it off. With regards to vaccines, we have received numerous reports of vaccine errors during COVID, and we did write a bulletin about it. And so I've included the link, and I'll maybe pop it into the chat box. It was about how to, it was called the Update Analysis and Shared Learning from COVID-19 Vaccine Errors. And some of the errors we received recently are with regards to children receiving adult doses of COVID vaccine. And so we're working on some new newsletters and sidebars to help with that as well.
Great, thanks so much, Alice. And I think what we'll do as well, as much as possible, any really pertinent links shared today, we'll make sure those get sent out when we send out the link to the recording. So some follow-up. So you can either grab it in the chat or we'll send it to you after to make sure that you all don't miss important information. Okay, a question for Samantha. In the study looking at self-harm poisoning, were alcohol and other recreational drugs considered as self-harm poisons? And also were medications used in combination with other substances like drugs and alcohol?
Yeah, so that's a great question. I'll start off, I guess I can say we used ICD-10 coding to determine like groups of substances. And we did look at alcohol, and surprisingly, the rates were very low. So for 10 to 14-year-olds, there were no males who had been hospitalized, like very few females. The rates, like I said, very low for 10 to 14-year-olds. 15 to 19-year-olds were slightly higher, but still, like, of our list of substances, it was in the bottom two. So I was surprised at that one, looking at that as well. And I'm not sure if maybe they're just going to the emergency department and not actually getting admitted to the hospital. So that could be why, because these are hospitalizations. And then did we look at, I think, other recreational drugs was the question. We did have a group of other substances. So they may fall in there. There's also like a category narcotics and psychodysliptics. So depending on what type of recreational drugs, they would be categorized in different groups. But everything other than like those two groups that I were talking about did have much lower rates. And then I think the question was looking at alcohol with combination of drugs. We did not look at that, but it could be interesting, but I think we'd probably need to do that for like emergency department, just because the hospitalizations involving alcohol were so low in frequency. But good question.
Yeah, that makes sense. Yeah, really important context for where the data are coming from as well. Thank you. Okay, another question for you, Samantha, specific to your analysis. The question is, what is the proportion of missing value for residents? I'm not sure if you have that on hand.
I don't have it off hand, but we did look at it and it was quite low. It was, I believe, less than 5%. I think it was even less than 3%. So it was quite low.
Okay, great. A question for, I guess, the Health Canada team. Where did it go just now? One of our participants said they're having trouble finding the aromatherapy monographs, and if a link could be shared. Christine, I see you're typing in the QA. Maybe we can add that in the chat as well if you have it handy. And if not, we can always follow up. Just you're typing away, putting you on the spot there. Thank you so much, Christine.
I'll add it to the chat right now.
Wonderful. Thank you so much. It's great to be able to find those before, well, it's top of mind for everyone. Thank you so much. Okay, another question that is, I guess, a bit directed at Samantha again. This question was actually submitted in advance, asking about if these type of data are available for what's happening related to this in Ontario, and also about, you know, how does the rest of the country compare to BC. I can start with, we did actually reach out to the Ontario Poison Centre because we did have this question in advance, just to get a sense of their response, because each of the 5 regional poison centres in the country do track the data for the calls they receive. There's also, of course, the additional health data for hospitalizations and ED visits. The Ontario Poison Centre is looking at this topic in their data, so if they do have results to share, we can share those out. So I just wanted to share that update that we're looking in to see if we can find any information specifically from Ontario. But in terms of comparisons of the trend in BC to the rest of the country, you know, Samantha, you pointed to some of the notes from the literature in Canada and the US that you looked at when you're in the foundation for this study. I don't know if you want to comment on how your findings compared to the literature, or if you've had a chance to have any conversation or see any comparisons with studies from other jurisdictions.
Yeah, I can comment on that a little bit. So the data we used was from the discharge abstract database. So it does have information from Ontario. I have never looked at that, and I'm not sure if anyone has looked at that. But in terms of comparing our results to the published literature, it's definitely in alignment with other studies that have been published. There haven't been a whole lot of studies specifically focusing on this age group, especially studies that have broken it down by socioeconomic status or geography, or even by substances. Maybe a few more for substances, and generally, like, everything we've found is in agreement with other jurisdictions, especially like the substances component, with the antidepressants being high up on the list of substances used for self-harm poisonings.
Great, thank you. And in terms of Ontario, yeah, you mentioned, you know, it's one thing to have data access, it's another to look at the type of analysis that you did. But I did want to mention to those who may not be familiar, there are injury data available for Ontario through Public Health Ontario. They do have dashboards that are publicly available for hospitalizations, emergency visits, and deaths in Ontario for certain levels of injury data. You might find some information there on poisoning as causes and age groups and sex there as well. One other question, or just a kind of, not a specific question, but we have someone who's particularly interested in poisonings on the job. So just wanted to open it up to any of our speakers, if this is anything that you address in your work, or if there's any commentary we can offer on this. If not, that's okay as well. But just wanted to open it up in case you do touch on this at all in the work that you do. Looks like that's a little out of scope for what we have today. But if there is something that any of our participants are particularly interested in relating to poisoning, please let us know. We're happy to follow up, but also we are looking to do another one of these series for next year. So we've just wrapping up a 3-part series that Claire has led on behalf of Parachute this year. We're going to be doing another 3-part series. And we're always interested to know what people would like to know about, so that we can make these really useful and valuable experiences and tap into the amazing expertise we have across the country, as evidenced by our speakers here today. So I think we will wrap up the Q&A session there. I don't see any more questions coming in the chat box. So thank you again to all our presenters for answering these questions and bringing your expertise here today. Claire, back over to you.
Thanks so much, Steph. I do see here Richard has chimed into the chat that poison centers do collect information on location of exposure, which includes the workplace as well. So a good source to check as well. So yeah, I think we'll wrap up early here and let you all get back to your Thursday. But thank you so much again to our presenters, Alice, Samantha, Christine, Jessica, Dana, and Lori. Really appreciate your time and you lending your expertise to this topic in this webinar series. We can't say thank you enough. So yeah, thanks again, and thanks everyone for tuning in. Again, you will be prompted to fill out an evaluation form, and we'd love your feedback on this presentation and this session. So yeah, we'd appreciate any comments you can leave us. So thank you very much, and enjoy the rest of your day.